but not put it in the first.
Yes,
First of these drugs, aminophyllene, dopamine, glucagon, and glycopyrrolate. Glycopyrrolate, you know, it is an anticholinergic with sedation that is different from the same family with atropine, but a different action. So these.
When I think about the aminophyllene and stuff, when I recognize or know the isoprenaline, isoprenaline is not working.
If adrenaline, isoprenaline doesn't give any sustained action.
After how many milligrams?
After how many milligrams? For example, if you give 2 to 10 mic of adrenaline, 2 to 10 mic of adrenaline per minute, okay, and keep him under monitoring. Why you are doing monitoring? Why you are doing monitoring?
To see if it's responsible or not.
To see the progress. So if I want to say after 10 to 20, it is not right from me to determine or to say 20, 30, if I have no any idea about the pharmacological response, pharmacokinetic. We have a pharmacodynamic and we have pharmacokinetic. All of us different in our metabolism and response to drug. One of us can respond very well to drug. Others they don't show a good response to drug. So just put him under your monitoring, and you will see when it will need the alternative drugs. So we can't judge this adrenaline or isoprenaline that lasts 1 hour, that lasts 2 hours, that lasts 3 hours. No. All in all, we have to put in our mind, we have to keep him under our vision. Then switch to alternative drugs. Or if alternative drugs, it doesn't show any good response, so the last choice, transcutaneous or transvenous pacemaker. To prevent assistor, to prevent risk of assistor. Why? Because this patient may have had MOPTIS type 2 or complete heart block with wide QRS. So this category, it doesn't reverse by alternative drugs or pharmacology. The best option to keep him on pacemaker. Okay?
I'm sorry. We have like about 8 options for the inotropic agent. How we can decide which one to choose first, and can we use,
Atropine first.
Can we use some of them parallel to each other?
No. Don't use the parallel with each other. Atropine, why atropine? Look, what's your name?
Farma.
Farma.
Yes.
The option of anything according to the availability. Atropine is available, cheap, affordable, accessible, any time, everywhere, safe, can be given. But isoprenaline, there is no affordable, there is no available in our country. So is that right to say isoprenaline? We don't have isoprenaline. Adrenaline and crash trolley, but not always. From Mosul?
Yeah, Mosul.
Adrenaline. And I'm so sad about this news. Adrenaline is the corner of.
Yeah, doctor, we are talking about something universal, something algorithm, stepwise.
Atropine.
We don't care about if it's not available somewhere or not. Scientifically, what's the best
Atropine.
option to start with?
Atropine, adrenaline, isoprenaline. Alternative drugs, aminophylline, dopamine. This is a guideline.
Okay.
Look, problem. Atropine, like okay, isoprenaline, adrenaline. Doesn't matter which one of them is available. Adrenaline available more than isoprenaline. Therefore, I'm already mentioned adrenaline because we don't have isoprenaline. Okay. Alternative drugs. Look, it doesn't mention transcutaneous above alternative drugs. We are still in pharmacological treatment. Alternative drugs. These alternative. Aminophylline, dopamine, glucagon, and glycopyrrolate.
In this
Okay.
order.
Huh?
In this.
This cascade, not jumping above. Maybe if you run parallel, you will facing a big problem, tachycardia and hypertension. Both of them increase oxygen consumption. And very high possibility to precipitate myocardial infarction or myocardial ischemia. Synergism.
And
Synergism.
in cases of overdose of beta blocker and calcium channels, some of the beta
Glucagon.
receptors, they get occupied.
Glucagon.
They get occupied with those receptors. Then you can choose glucagon that in another way can increase the rate of the heart.
Glucagon is not available.
Yes.
And if you
In case it was available.
if you even there, not available. According to your request, give me glucagon. They will give to you glucagon, or maybe glucagon in the crash trolley. But the most affordable and accessible drug, atropine. So why I'm using glucagon if I don't know the causes of bradycardia? Glucagon is an inhibitor hormone. In guideline that use in beta blocker overdose and in oral hypoglycemic overdose to reverse the hypoglycemic side effect of oral hypoglycemic drugs. Okay, but it is not justification that okay I use glucagon to increase heart rate whatever the cause. No, maybe it doesn't act. It has no any benefit. Atropine, okay, aminophylline, dopamine, and glycopyrrolate. This is simply the bradycardia algorithm. So far, so good.
I have a question, please. Once in ER, I faced a middle-aged male. A week ago, he put a pacemaker. Presented to ER with a low bradycardia, 45 to 46. Tamam?
Which is good.
And he was hypertensive.
Which is good.
And he was
And he
complaining
don't have-
about...
He don't have any sign and symptoms of an instability.
No, he conscious by...
So why I interfere with
There
the?
is no deficit, then no need to intervene.
No need for intervention.
But he was complaining that in house the rate was 38 or 37.
Okay.
Yeah. So he run out to the ER and became 45, but he was hypertensive.
Okay.
Like one-
What about his blood pressure?
190 over 110,
Okay.
something like that.
Then I can to give him GTN, NGC, venodilator, drop blood pressure, and enhancing vasodilatation with give reflex tachycardia, even small or low rhythm above his resting heart rate. Maybe reach to 60, maybe reach to 55, which is better than 38.
But will such patient with ICD have reflex tachycardia?
Of course, but not significant. Not significant tachycardia, not like normal heart. No, reach what is called programmable. Programmable mean reach to the target and doesn't reach over the target. This is the idea behind
I mean, the physiology of that case, when he had hypertension, the hypertension systolic and diastolic, so the pacemaker lowered his rate to regulate it.
Okay.
That was the physiology of it?
So
Yes, yes.
So, yes.
Yes, vasoconstriction.
Yeah.
how would the pacemaker know the patient's hypertension?
No, not pacemaker. Baroreceptor, not pacemaker.
The valve.
Baroreceptor drop the heart rate as a reflex of vasoconstriction due to an increase after load. Make sense?
Yes.
Baroreceptor, no.
Pacemaker will not sense.
Blind pacemaker.
Yes.
So this is simply what does it mean, the bradycardia and their treatment. This treatment. Regarding to tachycardia again, the tachycardia, it has no any sign or symptoms. Why I interfere to treat a tachycardia when the heart rate 130, 140, while the patient is young, 30 or 35 years old, maybe SVT, supraventricular tachycardia, a short-lived tachycardia, and can manage as we know from the subsequent slide. But the tachycardia, first of all, as I said before, once when the patient comes to the casualty, a very important thing to give him oxygen and IV access, and search for the causes of the tachycardia. Causes of the tachycardia is very obvious, either electrolyte disturbances or due to hypovolemia. Thus, then when we correct the hypovolemia and volume status, then the tachycardia definitely will be treated. But the problem if the patient has rate 160, 190, and the sign of the instability like syncope, shock, vitally unstable, sign of ischemia, and sign of myocardial or heart failure, then what shall we do? There is no any option other than DC shock. Cardioversion or defibrillation. What do you think? Cardioversion.
Synchronized D wave?
Why? Is there any difference between cardioversion and defibrillation?
Yes.
Synchronized on some point.
No, not synchronized.
Emergency elective. You mean?
No. The defibrillation using high voltage for reverse the abnormal ventricular rhythm. Defibrillation used for reverse the abnormal ventricular rhythm and used in high current voltage. Why? Because the ventricle has a bigger mass than the atria. Ventricle has a bigger muscle than the atria. Cardioversion, because the atrial wall is thinner than the ventricle, it doesn't need for high voltage. So cardioversion for atria and use with a low voltage 50 to 100, no more, and can reverse the atrial rhythm, while defibrillation used for reverse the ventricular rhythm. How many times or how many shock we have to give it? 3 consecutive shock. 3 consecutive shock, and then give the 300 milligram of amiodarone over 10 to 20 minutes. We will see. Keep that number in your mind. 300 milligram over 10 to 20 minutes, and we will see why. So later on, if the rhythm not responding to such a DC shock 300, then we can give a maintenance of amiodarone 900 over 24 hours to make IV block, not to biscuit the impulse coming from the atrial fibers. So this is exactly the treatment of unstable tachycardia. So if there is no sign of instability, there is no syncopal, no shock, no sign of heart failure, no sign of ischemia. What shall we do? ECG, 12 lead ECG, and to analyze the QRS. Broad QRS, narrow QRS. Broad QRS, if the QRS more than 0.12 seconds, and narrow QRS if less than 0.12 seconds.
Yani 3 small square.
Exactly, 3 small square. More than 3 small square, less than 3 small square. And narrow QRS tachycardia, stable. So we already manage unstable tachycardia. Another classification, it will classify to regular narrow, irregular narrow, regular narrow, irregular narrow. Regular narrow, how can we treat it? Or what are the rhythm below the regular narrow?
Regular narrow?
Yes?
So it could be
SVT.
SVT. We try with Conzo or something.
SVT, Wall Parkinson-White syndrome, pre-excitation and whatever the... Yes. So what are the treatment? Pharmacological, non-pharmacological. This is exactly what I give it. This is exactly the cascade that hopefully wherever you go you can to talk by such way. Wherever you go, United Kingdom, United States, so you have to be systematic. So a Valsalva maneuver, for what Valsalva maneuver? For stimulation of vagus.
Carotid massage.
Carotid massage, right or left or bilateral.
One of them.
Why?
You will
It could be contraindicated sometimes.
No,
it could be.
you will
It is
shrink
contraindicated.
the carotid
No, I mean,
and you diminish the supply to the brain.
No, not that cause. No, not that cause. Keep that in your mind. That carotid massage is contraindicated in the age above 60 because showering of atheroma. First, second, right carotid massage stimulate right vagus that supply the SA node, while the left vagus supply the IV node. So inhibit discharge and increase amount of block when we are doing bilateral carotid massage. This is the idea, but not interfere with the cerebral circulation because the artery has a thick, has a thick wall and uncompressible, not like vein. Even when you put a pressure, there is impulse that transmitted to reach the blood from the heart to internal carotid artery through the.
So it's better to do it bilateral.
One either right or left. This is the idea. So other than Valsalva maneuver,
Cold ice.
exactly, cold water and sweeping of the soft palate by cotton, or cotton do inside the tympanic membrane just to stimulate the vagus. If all these happen, not get a good result, we have to use a pharmacological drug. What kind of pharmacological drug?
Adenosine.
Adenosine. How many milligrams of
6
adenosine?
Another 6.
Another, no, 6, 12, 12. After 3 to 5 minutes. Whatever you are saying and studying, and you know, and you getting experience, don't forget to monitoring the patient after each step of your medical treatment. Because as I said, there is no human similar to the other human being. Different. So 6, 12, 12, if not responding to such adenosine, and adenosine should be given in a very rapid and very fast way,
Yes.
and keep in your mind the contraindication of adenosine, asthma, heart block, and anaphylaxis could be. So if not responding well to adenosine, the third step, sorry, either beta blocker or calcium channel blocker, which more has not contraindicated For example, if the patient has tachycardia while he's asthmatic, is it good to give him beta blocker? Then calcium channel blocker. So this is exactly what we will have to do in regular narrow QRS tachycardia. What about irregular tachycardia? Irregular narrow tachycardia. And what are the rhythm belong such a category? Irregular narrow QRS. Atrial fibrillation. So we have to classify from the history this atrial fibrillation. The timing of atrial fibrillation before 48 hours, after 48 hours. Before 48 hours. And why we are classified exactly this time or thrombosis. If after 48 hours there is no role for DC shock, and we have to put the patient on anticoagulation, amiodarone, and digoxin if he has a sign of heart failure, and prepare him over 3 weeks, and then we can to give him an elective DC shock, okay, and consider that a major surgery, like a major surgery. So rate control, rhythm control, and anticoagulation for eradication of any possibility of thrombus existing inside the atrial chamber. Okay, this is irregular narrow. Yes.
More than 48 hours. I think I've heard we can make transesophageal echo, and if there is no thrombus, we can cardiovert.
Why we are doing this intervention? Okay, then if it is established or not established, this is beyond 48 hours, and there is no debatable. There is no debatable to put him on anticoagulation as a prophylaxis. So why we struggle and make the patient under threat of aspiration? So from my perspective, doesn't need 48 hours beyond 48 hours. Okay, then treat him rate and rhythm control with the anticoagulation for 3 weeks, and then prepare him for elective DC under deep sedation or even anesthesia. So this is irregular, regular, narrow QRS. What about the broad QRS? Broad QRS, again, classified into regular or regular. Regular, what is the rhythm belong the regular wide QRS? VT with undetermined branch block. VT with undetermined branch block. So VT with undetermined branch block, remember the amiodarone 300 milligram 10 to 20, right? Here we have to give 300 milligram 10 to 60, 10 hour 20 to 60 minutes. Why? Because the patient is stable. Why we are rushed to give him amiodarone over 10 to 20? Look, 10 to 20, 10 to 20 amiodarone, while here 10 to 60 or 20 to 60. Why this difference between here we are facing unstable tachycardia, but here stable tachycardia? So we don't be rushed to give amiodarone in such time. Another rhythm, SVT with bundle branch block. SVT, it is regular narrow, so treated as regular narrow, treated as regular narrow complex tachycardia. So you know the approximity and how to link between each other. Although the algorithm is very tough and very complicated, but if you are understanding in a simple way, maybe you will never miss it. It's very important to know that. Very important. So regular. This is a regular broad QRS more than 12 seconds. What about the irregular IF with bundle branch. Therefore, that the ECG present with wide QRS. If IF without bundle branch block categorized under a regular narrow. But IF with bundle branch, okay, irregularity with the broad QRS. How come? Treated as a regular sin. Treated as irregular. Treated for irregular narrow complex. Why? Because whether atrial fibrillation is associated or doesn't associated with the bundle branch, it is AF. It is AF. So I have to do rate, rhythm control, and anticoagulation. Another last rhythm belong the irregular wide QRS. Excellent. Torsade di pointus or polymorphic ventricular tachycardia. Do you know the presentation of polymorphic ventricular tachycardia? شايفيها؟
بس بالاي سي جي شايفينها.
ها؟
ما شايف الحالة.
ما شايفينها. The patient dead. Or be dead.
I think it's present.
Shock patient.
Oh, he feels shock.
This is stable.
Stable one. Like he
This
feels.
is stable.
Stable with
This-
dorsal point.
Of course, stable. Stable.
بالصدفة.
Stable.
بس يقول قلبي ما أدري يركض سريع شيء.
Okay. Good. This is torsade di pointus. Polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. Torsade di pointus.
How's the patient present?
Tachycardia.
Just yeah, he complained from tachycardia.
Tachycardia.
Yeah.
And maybe chest pain.
Chest pain.
But cardiovascular stable, chest pain, shortness of breath, so not chest, shortness of breath. Shortness of breath. Look, this is a polymorphic ventricular tachycardia. Neither IF nor SVT. Okay? This is a polymorphic ventricular tachycardia done, treated by
Happen in all these literally.
magnesium sulfate. Magnesium sulfate. How many milligram of magnesium sulfate? Huh?
2 grams.
Not milligram. 2 grams. 2 grams. What are the other indications of magnesium sulfate? Preeclampsia.
الرفلكسيا.
Exactly. Refractory. Excellent. Refractory, not refractory bronchospasm only. Refractory bronchospasm and refractory convulsion. If the convulsion doesn't responding to conventional anti-epileptic. The other,
With the
this is
toxicity
beyond.
also, I think.
No. Just absence of, because of
And
hypocalcemia,
urine
absence
function.
of knee jerk,
Knee jerk.
absence of knee jerk. That's the indication of stop the magnesium sulfate, even in preeclamptic
Preeclampsia.
toxemia.
You have to monitor
Even in
your
preeclamptic
notebook.
toxemia. So 2 grams IV over 5 minutes,
IV direct.
10 minutes, IV direct, yes.
Yes.
IV over 10 minutes, over 5 to 10 minutes exactly, over 10. Me, I'm using half of the dose within 5 minutes and the rest of the dose within another 5 minutes. And I saw very nice response, very nice response, yes.
Are there any alternatives to the are there any alternatives to the magnesium? Any
Torsade di pointus?
Yeah.
According to the guideline, and I have to stick to guideline. Yeah, no.
What there are no antidotes to the magnesium phosphate?
Antidote?
Yeah, there is no.
No, there is antidote of
In
magnesium
the
sulfate.
hospital.
Calcium.
It's not present in the form.
Calcium.
Calcium gluconate.
Calcium gluconate.
Yeah.
Calcium gluconate not available. Adrenaline not available.
We are
This is not a hospital.
Give him champagne. Champagne available.
Okay.
والله ده سامع not available.
ها؟
غالي أكثر.
Champagne available.
وين داوم بيتر؟
Everywhere.
وين داوم؟
أنا؟
إيه.
أنا داوم بالعراق.
عندكم شامبين بالطوارئ؟
شو عندنا؟ عندنا كريستال. المشكلة يعني عندنا كريستال.
كتلار.
أصلاً كريستال يعني شي بردان شامبين.
إيه.
تعالوا لا دخلوا بالسياسة. هم سياسيين عندهم شو اسمه متاجر مال المخدرات.
إيه صح.
أم علينا
وقت داعش هم كانوا يتاجرون بالسجاير
سجاير.
هم كانوا مانعينها وهم يبيعوها.
ها سجاير هذا مروانة هذا مو سجاير. مروانة. طاقات علينا كلهم ترى. So hopefully I can give the optimum what you need. This is my all best.
Thank you.
Most
But one question, please, regarding the dorsats. We did how many attempts for the magnesium sulfate to give response? And when the patient is giving for arrest, then we forget about it. We're going to arrest management.
if you want to know the talkative doctor or lecturer, you can ask him this question and he will back to you within 30 to 45 minutes. No. Not me. Give 2 grams and follow him. And monitor him hourly. So then you can pick up the early sign of drugs washout or drug finish of a drug. See? But the action, for example, شو اسمه؟ Ferman. For example, if I got headache and I'm taking paracetamol, maybe the half-life of paracetamol, according to what was mentioned in the pharmacology, it will reach optimum 2 to 4 hours. This is a pharmacology. It was mentioned and lasts for 6 to 8 hours. Sorry? 5 minutes? Okay. We're already finished. 6 I'm thought that 5 minutes paracetamol. So 6 to 8 hours. Regarding me, my body. But your body maybe last no more than 3 hours. Other body lasts 16 hours. It is a matter of metabolism and hormones, temperature, pharmacokinetic, pharmacodynamic. So nobody can judge this 2 grams lasts for 3 hours. No. Give it and follow the patient.
Okay, if it went into arrest, then we start the arrest.
Why arrest? Why arrest?
Sometimes it's torsades. It could be going to. We set the patient stable.
Arrest? Okay. Arrest.
We get arrest. Fall to the ground.
Arrest mean Farman. Arrest mean unstable. Then put it under the category of amidaronan. Amidaronan and decision.
Victor, sorry. It's a question. We had a case. This after DC shock, 3 attempts, we give amiodarone. And how is the blood pressure is low, we give any other medication apart from amiodarone. If the patient is hypotensive, and we give amiodarone for tachycardia, like resistant BT, and he not responding to DC shock, and we give
Tachycardia?
Yes.
Plus hypotension.
Hypertension, yes.
Look.
We saw this case during resuscitation.
Okay. Amiodarone plus digoxin if any sign of heart failure.
Yes, look like that. Yeah,
We can give.
okay.
Amiodarone plus digoxin, and digoxin, the action of digoxin is positive inotrope. That increase. There is an art to put this category upside down in a legal and right way. Legal and right way. Because this is a picture in our brain, and we see this picture in 4D, 4 dimension. Not copy paste this picture in our brain, and there is no any kind of maneuver. You know what's meaning maneuver? Munawara. Maneuver to put one of the category under the categories of other life-threatening situation. This is what I mean. Hypotension, tachycardia, not responding to DC, not responding to amiodarone. Okay, digoxin. Look, amiodarone. Consider digoxin or amiodarone as evidence of heart failure, hypotension. Heart failure, hypotension. So far, so good. Hopefully, you get it. Most of the information that I was presenting. How much you get it? 60, 40?
How much?
Yes.
18, 75 to 80%.
No. Proud. Proud. Same of ICS lecture?
Yes, yes.
Yes. Good.
Was well present.
It's a basic physiology.
Actually, this is my interest. To give a cardiac problem, because even in my daily work, I think I'm not the only one, but I am the one that working much of the cardiac patient for non-cardiac surgery, anesthesia of cardiac patient of non-cardiac surgery in Basra. So any cardiac disease that scheduled for surgery, they do consultation for me to give them anesthesia, whether in public or in private hospital. That is why I have to know in details what are these drugs and what are the algorithm. Not to read it and give it. To do it, the most important. That is why I'm sorry about the lecturer of a university belonging to the Ministry of Higher Education, especially the surgeon,
They just leave the slides.
the anesthetist even. They are like to talk, but they couldn't to do practice.
Or deliver the info.
I'm already, when I give lecture, I told to them, anybody try to proud of himself, you will discover within 2 years later. Of course, he's talking confidently, but he don't know about what is his future when this student sitting on the chair, he will come to be rotator under his supervision and find his lecturer, he's nothing. He's nothing. Believe me.
It wasn't clinically oriented. Special.
Clinically
Oriented.
the lecturer,
Most of the lectures now, they are not clinically oriented.
I don't need for clinical orientation, just clinical orientation and hand practice, hand skills. No? So he can talk hours about the overloads, about the appendectomy, but call him to do appendectomy 3 hours. 3 hours.
I have a question behind the lecture. You said in acute coronary syndrome, we have option to give antifibrinolytic or a PCI. Is there
Finish. Last.
if we are 2 hours far away from the center of cardiology, we have antifibrinolytic and we confirm it by clinical that the case is STEMI.
STEMI?
Yes.
Okay.
We can give antifibrinolytic and then refer to CCU center like coronary care unit center.
Yes.
Doesn't this give an antifibrinolytic delay the PCI?
No, either fibrinolytic or PCI.
Either.
Yes. 30 minutes from door to needle, fibrinolytic. And if not responding to fibrinolytic, then we don't have any option other than PCI. But the first fibrinolytic, not PCI, because PCI need a time for preparing the patient and for preparing the theater.